Today's webinar is part of a series of webinars being co-hosted by the Chronic Disease Prevention Alliance of Canada, or CDPAC, and the Public Health Agency of Canada's Centre for Chronic Disease Prevention. Today's webinar is entitled Mental Illness in Canada. We're extremely pleased to be co-hosting this webinar, which is going to provide an overview of the status of mental illness in Canada, as well as the Public Health Agency's activities in this area. Mental health is of particular importance for CDPAC since we know there's a complex interrelationship between mental well-being, physical health, and chronic disease. So my name is Bill Callery. I'll be moderating the webinar, and I'm Manager of Programs and Knowledge Exchange at CDPAC. For those of you who aren't familiar with CDPAC, we're a network of many of Canada's largest national nonprofit healthy living and professional health organizations, and we share a common vision for an integrated system of research, surveillance, policies, and programs for maintaining health and preventing chronic disease in Canada. We've included our website, our social media coordinates at the bottom, so encourage you to connect with us, check out our upcoming events. You can even view past webinars and materials from our website. So really pleased to have three excellent presenters today. Our presenters, Louise McRae, Siobhan O'Donnell, and Lydia Lucane, are part of the Public Health Agency of Canada's Chronic Disease and Conditions section with their Surveillance and Epidemiology Division. Louise is a senior epidemiologist involved in surveillance relating to musculoskeletal conditions, chronic respiratory diseases, and mental illness. Siobhan is also an epidemiologist involved in musculoskeletal conditions and mental illness surveillance. And Lydia is an analyst involved in diabetes and mental illness surveillance, as well as analysis of health adjusted life expectancy in people with and without depression. So welcome to our presenters. And now, without further ado, I'll pass the controls over to Louise.
Great. Thank you very much, Bill. And welcome, everyone, echoing the welcomes. So I'm going to start off just giving a bit of an overview of our mental illness surveillance work here at the agency. So this slide just shows an overview of what the team is going to be presenting to you this afternoon. So starting with this overview of our work, and then my colleague Siobhan will be presenting on the impact of mood and anxiety disorders in Canada, with some highlights from the 2014 survey of living with chronic disease in Canada on mood and anxiety disorders. Then I will present some highlights from our Canadian chronic disease surveillance system on the use of health services for mental illness. And then last but certainly not least is Lydia, who will be presenting on depression and health adjusted life expectancy in the Canadian adult population. So I'd like to start with this, providing a bit of context in what do we mean by public health surveillance, and in particular for mental illness. It's the tracking and forecasting of health events or health determinants related to mental illness. It's done through the regular collection of the best available data. It's the integration, analysis, and interpretation into surveillance products and dissemination to those who need the information. And it's done to inform public health actions, policies, and programs. So within the Public Health Agency, the Surveillance and Epidemiology Division in the Centre for Chronic Disease Prevention has the lead for mental illness surveillance. And some of our key data sources include the Canadian Chronic Disease Surveillance System, which I will refer to as CCDSS. And this consists of physician billing and hospitalization administrative data from the provinces and territories. We also use national surveys such as the Canadian Community Health Survey and the Survey on Living with Chronic Disease in Canada. And these efforts are conducted in liaison with, we have a mental health and mental illness surveillance advisory committee with experts from the academic areas, as well as the consumer organizations such as CMHA and the Mental Health Commission. We also are guided by a mental illness CCDSS working group, as well as the CCDSS Science Committee. And we're also part of a mental health and addiction information collaborative, which has been spearheaded by the Mental Health Commission's Knowledge Exchange Center. So a bit of a history of our work. It really began prior to the creation of the agency under Health Canada in '99 with development of some surveillance indicators for mental illness. And then in 2002, the first report, a report on mental illness in Canada, was produced in partnership with the Mood Disorder Society of Canada. And then a second report was released through the Public Health Agency in 2006. That's the Purple Report, The Human Face of Mental Health and Mental Illness in Canada. And then in 2008, the Public Health Network's Task Group on Surveillance of Chronic Disease and Injury endorsed a plan to expand the CCDSS using provincial territorial health admin data to include mental illness, among other conditions. So following up on that, we began to pilot that in 2009 using the admin data for the surveillance of mental illness and mood and anxiety disorders. In 2011, mental health was identified as a priority within our branch, which is the Health Promotion and Chronic Disease Prevention branch. And 2013's budget committed the agency to reallocating $2 million to improve data collection and reporting of mental illness and mental health. So in 2013, we began to develop the survey, which would be the 2014 survey on living with chronic disease in Canada on mood and anxiety. And in 2014, we began further expansion of the CCDSS work looking at schizophrenia and delusional disorders, conducting some pilot work there. And then this past year, in the summer, we released two products. The first is a mood and anxiety disorder in Canada fact sheet, which is based on the SLCDC survey, which Siobhan will be speaking to in more detail. And then the second was the report from the CCDSS on mental illness in Canada, which I will provide some more information on shortly as well. So this slide just gives an overview of how we disseminate our information. So we use data cubes on the Public Health Agency's website, as well as open data. We use listservs such as we have a chronic disease update listserv, webinars such as this one, peer review papers. On the info base where the data cubes are, there's also a chronic disease data blog, and there has been one dedicated to mental illness, as well as websites and social media. So just going forward, we're planning to continue the expansion and reporting of mental illness using health admin data, as well as routine surveillance of population survey data. And we will also be exploring the results of a project currently underway to link data between electronic medical records, survey data, and health administrative data to better understand what's being captured in each and where the overlaps and gaps are. So that's the overview part of this afternoon's presentation, and my contact information is there. It will be available after as well. And so at this point, I will turn things over to Siobhan, who will discuss the impact of mood and anxiety disorders.
Thank you, Louise. And thanks for the opportunity to speak to you today, highlighting some findings from the 2014 survey on living with chronic diseases in Canada, with the focus being on mood and anxiety disorders. Just to give you some background information, mood and anxiety disorders are the most common types of mental disorders in Canada. In 2013, it was estimated that approximately 3 million Canadians are living with these disorders over the age of 18 years. Both disorders have been shown to have a major impact on those living with them, their daily lives. However, the good news story is that professional care combined with active engagement in self-management strategies can foster recovery and improve the well-being of people affected. So on account of a lack of information about the experiences of Canadians living with mood and anxiety disorders, the Public Health Agency, in conjunction with StatsCan, conducted this survey in order to provide new information both on the impacts and the approaches professional, and self-management approaches used to manage them. The SLCDC on mood and anxiety disorders is a 20-minute cross-sectional follow-up survey to the 2013 CCHS, Canadian Community Health Survey. And with respect to the objectives, basically it's to assess the impact of mood and anxiety disorders on Canadian adults, to describe how people with mood and anxiety disorders manage and identify the barriers to care and self-management strategies, and also to identify factors which influence mental illness outcomes. The final data file can also be linked to responses to the source survey, the 2013 CCHS, which enables us to have a very rich data set as we can then link and describe them both in terms of health determinants and comorbidities, and reduce respondent burden by having to ask these questions again. In terms of the target population, so as I mentioned, they're identified from the 2013 CCHS. It only included those 18 over with that identified as having a professionally diagnosed mood and anxiety disorder, and they were living in privately occupied dwellings in the 10 provinces. From the source survey, the source survey excludes people living on reserves in other Aboriginal settlements, persons living in institutions in certain remote regions of Quebec, full-time members of the Canadian Forces, and as well the territories were excluded, which comprise of about less than 3% of the overall Canadian population. These are the screening questions which basically identified the sample for the SLCDC. So they had to respond yes to either one of these questions. Basically, they're questions that are in the chronic conditions module of the CCHS, where we're interested in asking about long-term conditions. They're expected to have or have already lasted 6 months or more, and they were diagnosed by a health professional. So did they have a mood disorder, providing some examples of depression, bipolar disorder, mania, or dyspnea, or did they have an anxiety disorder such as phobia, obsessive compulsive disorder, or a panic disorder? This gives you a visual of the sample design. So from the 2013 CCHS, there were 65,000 respondents, of which 5,875 were potentially eligible for the SLCDC due to respondents either being out of scope or due to non-response. The final sample for the SLCDC was a total of 3,361, which was a response rate of about 69%. So with regards to the final sample, we are able to get reliable estimates at the national level for indicators overall with a minimal prevalence of about 3%. By sex, indicators with a minimal prevalence of about 4 to 8%, and by age, those specified age groups with a minimum prevalence of about 18 to 12%. It provides reliable regional estimates for indicators with higher prevalences between 7 and 18%. So from our sample, we are limited in terms of our ability to break down certain indicators by age and sex, especially among males, where it's not as common. And also the sample size does limit some provincial estimates. So here's the content. We have here 11 modules. The first module is more of a warm-up module. We're asking about general, self-perceived general and mental health. We have a module on confirmation of diagnosis, which also asks for age of which they were diagnosed, as well as age of onset of symptoms for both mood and anxiety disorders. We have a module on medication use, self-management strategies, their contact with health professionals, clinical recommendations that they may have received, restrictions of daily activities, also work activities. We have a module that captures both the quantity and quality of their sleep, also stress, including the sources of life stressors. Lastly, the social provision scale was also included. Survey questions were designed for computer-assisted interviewing because it was conducted by telephone. So now to give you a little bit of a snapshot of some of the key findings. So many reported poor, fair general and mental health, job-related restrictions, and high life stress. To give you a little bit more specifics, approximately 1/4 reported having fair or poor general and mental health. Approximately half required some kind of job modification to continue working. and then approximately 1/3 stopped working altogether. More than 1/3 reported quite a bit or extreme stress in life, and the main sources of stress being financial concerns, family, work, followed by health. In terms of activities of daily living, about 1 in 5 reported experiencing a lot of difficulties with basic activities, and these ranged from exercise, physical activity, all the way to the basic of bathing or dressing. In terms of professional care, most have either taken or are taking or have taken medications, but fewer receive counseling. Approximately 93% said they are currently taking or have taken prescription meds. But however, 1 in 5 only reported having received psychological counseling in the past 12 months to help manage their disorder. In terms of engagement in self-management strategies, overall is suboptimal, while about 2/3 said that they had ever exercised or engaged in physical activity. A substantially less said they were continuing to exercise on a regular basis. About 70% said they adopted good sleep habits. In terms of developing a crisis plan, it was basically just a quarter, more than just a quarter, had said that they had developed that type of a plan. Of those that have mood disorders, only about 15% said they had used light therapy. In terms of meditation, less than half had used meditation, but the majority had said that they had attempted to self-educate themselves at 83%. Summary of findings: mood and disorders, they have a profound effect on Canadians, adults, to carry out daily activities. While the majority are currently taken or have ever taken prescription medications, their engagement in many of the self-management strategies, such as physical activity and meditative practices, is less than optimal. Addressing barriers, providing targeted recommendations may help improve the management of these disorders. The data was officially released in October 30th, 2014, and can be publicly accessed. StatsCan has made it available in their research data centers, so that can be applied for. And these research data centers are located throughout the country at many of the major academic centers. In terms of our knowledge products, so how we've been able to disseminate some of the information that's coming out of this survey, we have, as Louise has mentioned, we had a fact sheet that was published in the summer. We also have a customized data cube that people can glean more, answer whatever question you're interested in looking at in terms of slicing the information. We have sort of a matrix table there with different demographics and different healthcare outcomes. You can explore the data through the cubes. We had a poster presentation at CAPE 2015 Annual Scientific Symposium, and currently we have a suite of peer-reviewed articles underway, which we're planning to publish in the fall of 2016 in our branch's journal. They cover a variety of topics, including the methods of the actual survey, how it was conducted, and also a description of the final sample and both the strengths and limitations of the survey. We have a paper on activity limitations, disability, and work-related restrictions, a paper regarding more the factors associated with well-being while you're living with these disorders, time to diagnosis, clinical management, both medication and counseling, and also self-management, specifically focusing on physical activity and exercise and the impact that has. And if anyone's interested in finding out more about the survey, StatsCan, you can go to StatsCan's website. As well, on our website, as Louise has mentioned, you can see a number of the products that have followed upon the release of the survey. And now I'd like to hand it over. This is my contact information. I'd like to hand it back over to my colleague Louise, who's going to be presenting some highlights from the CCDSS.
Okay, thank you. So next on to some results from CCDSS, and just wanted to provide you with a bit of background. In 2010, CCDSS was expanded to include mental illness in the Canadian population. And so the results I'm presenting now are from the report I mentioned earlier, which was released in the summer on mental illness in Canada. And this was the first agency publication to report on this linked administrative health data, which included hospitalization and physician billing for the national surveillance of mental illness, and was the first agency publication to include children and adolescents under the age of 15. This was also a direct response to the commitment made in Budget 2013. This is just a screenshot of the report, which is available online. An overview of what the CCDSS is. It was formerly the National Diabetes Surveillance System. It started with surveillance of diabetes, and over the past 4 or 5 years has been expanded to include several other conditions, including mental illness. It collects information on prevalence, incidence, mortality, and use of healthcare services for selected chronic diseases and disorders. It generates summarized data for residents of Canada covered under provincial and territorial health insurance plans, which accounts for approximately 97% of the population. It does not include those covered under federal health programs, such as military personnel, Royal Canadian Mounted Police, and inmates of federal correctional facilities. So this diagram shows how the data is linked together. There's basically 3 different data sources. There's the insurance registry, which includes the demographic data as well as mortality. Then the hospitalization and physician billing data is where we're able to apply our case definitions for certain conditions, as well as look at comorbidities and health service use. And all 3 of those are linked together using a unique identifier. So mental illness was one of the first expansion components of the CCDSS starting in 2009. And the overall, or sometimes referred to as omnibus mental illness and mood and anxiety disorders, are currently part of ongoing national surveillance. The data in the report included 10 provinces and the Northwest Territories. We're not able to include the Nunavut data at the point of the report because the data were not available prior to '99, and Yukon was also excluded because of data quality issues. The data is collected retrospectively for 96-97 to 2009-10 at the time of the report. So the way that we defined mental illness was that to be a case, one had to have at least one visit to a physician with a diagnosis of mental disorder or a discharge from a hospital coded as a mental disorder using International Classification of Disease Standards, so ICD-9 or 10, and within 1 year. So in the case of mental illness, prevalence refers to the estimated prevalence of the use of health services for mental disorders rather than a true proxy for disease prevalence. This is due to the fact that we're limited to the people who are seen by a physician or admitted to hospital with a mental disorder or used health services. And we're also not able to include those who have only sought privately funded care, such as from certain community-based psychologists. We did have a look at CCHS data to try to estimate what proportion we might be missing of people who only see psychologists, and it's thought to be fairly small, but there's some additional work to be done to examine that gap more closely. Not all psychiatric hospitals and hospitals with dedicated mental health beds are captured in CCDSS. So for this reason, it's really prevalence of the use of health services. So this is a list of conditions that are included in the overall mental illness case definition. So mood, anxiety, psychosis, personality, psychosexual, substance use, mental retardation, and dementias. In the case of dementia, it includes dementia in Alzheimer's disease, but doesn't include the broader codes for Alzheimer's disease specifically. So on to some results. So every year, about 1 in 7 Canadians uses health services for a mental illness. That's about 5 million Canadians who received services for a mental illness in 2009-10. So we looked at over time by age group. So this is the age standardized annual prevalence of the use of health services for mental illness among those 20 years of age and over. And we can see here that the health service use has remained relatively stable across the study period from 96-97 to 09-10. It's higher in the 80-plus group, which is most likely due to the fact that dementia is included. So this is the same information but for children, so ages 1 to 19. And so we can see that there is more of an increase among the children, and the largest relative increase was among young adolescents between 10 and 14. So this presents age-specific annual prevalence of the use of health services among people 1 year of age and older by age group. And so we can see here that particularly among the elderly, they're more likely than children and adolescents to use health services for mental illness. Again, that's probably partly the dementia in there. This presents across provinces and territories, so age standardized annual prevalence by province and territory. And we can see here that across all the jurisdictions, women were more likely to use health services for mental illness than men. We also looked at some comorbidities. So we looked at asthma, diabetes, chronic obstructive pulmonary disease, hypertension, and ischemic heart disease. So this presents age standardized rate ratios for the prevalence of chronic diseases or conditions among people who used health services for mental illness versus did not use health services for mental illness. So you can see here that the chronic conditions were more prevalent among people using health services for mental illness. And in particular, the two respiratory illnesses, asthma and COPD, are more prevalent. This is due in part to smoking being a common factor in both, most likely. Some of the strengths of this data are that it's longitudinal data. It's virtually complete coverage of the Canadian population. There is the potential for data linkage studies since there's a unique identifier within the provinces and territories. The platform's fairly stable over time, and it complements other data through clinical records or EMRs and community surveys. Some of the impacts. This work, we're hoping, will provide evidence to support informed public health decisions and policy related to mental illness, and as well as track progress towards public health goals, such as the mental health strategy, which was developed by the Mental Health Commission. The high prevalence of coexisting conditions negatively impacts management of both mental illness and the chronic conditions, and mental illness will continue to be a public health priority. Some of our future plans for CCDSS include a second volume with similar information on mood and anxiety disorders, which will be released next year. We're also continuing the collection of data on mental illness and mood and anxiety disorders through CCDSS. And we are working on the feasibility studies on developing case definitions for other mental disorders, currently working on feasibility for schizophrenia and delusional disorders, as well as looking at studying the chronicity of mental disorders tracked through the CCDSS. We'll also continue to explore other comorbid diseases and conditions, such as stroke and other neurological conditions, and developing indicators of mortality. So the ways that we use similar ways to disseminate this information using web presence, social media, listservs, and stakeholder support. And the data is also available on the data cubes as well as the open data. So in summary, the health service use has remained stable between 96, 97, 09, 10 for mental illnesses. The largest increase was among young adolescents between the ages of 10 and 14. And Canadian adults, particularly the elderly, are more likely than children and adolescents to use health services for mental illness. Across all jurisdictions, women were more likely to use health services for mental illness than men. Just quickly showing the team that was behind all of this work, developing the report. This is the internal group. There was also several committees and working groups that provided support as well, and it takes a team to make these products. So. And this is, again, my contact information, and at this point I will turn things over to Lydia to present on HALE.
Thank you, Louise. Hello, everyone. So first, I would like to acknowledge a team listed on this slide who contributed their time and efforts to make it happen. So depression contributes significantly to the burden disease throughout the world. That, of course, includes Canada. Globally, over 298 million people are living with depression. This is the data from the Global Burden of Disease study. And in Canada, about 3.2 million, or 11% of people aged 15 years and older, report symptoms consistent with a major depression episode in their lifetime, and about 5% of them report major depression episode in the previous 12 months. This is the data from Canadian Community Health Survey Mental Health Component 2012. So depression has an important impact on health-related quality of life. It affects every aspect of individual's life. It affects functioning, mortality due to the intentional injury. It affects disability and healthcare utilization. Very few studies evaluated the overall impact of depression on health-related quality of life and mortality. So the objective of our studies were estimate health-adjusted life expectancy for Canadian adults aged 20 years and older with and without depression or without major depression episode in the previous 12 months. We also wanted to evaluate the health gap or HALE difference between people with and without depression and determine the contribution of mortality and morbidity components in the observed difference. So what is health-adjusted life expectancy? By the definition, HALE is an indicator of average number of years that an individual is expected to live in a healthy state. So basically it combines mortality and morbidity experience of a population in a single summary measure of population health. It is single indicators. It can be used to measure the burden of the disease or injury in population or risk factors, and it also can be used to evaluate performance of collective public health efforts. Also, HALE is very easily to understand by general public, by policymakers, and any other individuals that comparing with rates and proportions. So this slide shows you the survival curve. So if we'll take a cohort of people and we will follow them over their course life, so we will be able to build the survival curve or life expectancy curve, the upper curve, and the area under this curve will represent life expectancy. But of course, we all live not in full health all our life. So at some point of our life, we go through the illness and we're not living in full health. So the low curve is represent health expectancy curve, and the area under this curve represents health-adjusted life expectancy or health expectancy. So the area in blue in this graph is a difference between life expectancy and health expectancy, and can be interpreted as a year spent in unhealthy states. And ideally, we want to reduce it, to the minimum. So to calculate life expectancy and HALE, one needs mortality rates for populations, for the study population. So when we started to do this project, mortality rates for people with depression is not readily available from any data sources. That's why we used methodology to decompose total mortality rates, or mortality rates for total Canadian population by depression status. We developed this method while working on our previous HAIL project. So it's based on the mortality, relative risk, and prevalence of the condition. For that reason, we used 3 different data sources to estimate life expectancy in HAIL. So we used National Population Health Survey to estimate the mortality hazard ratio by depression status. This is a longitudinal health survey, and at the time of the study, the data were available for 9 cycles. So in the first cycle in 1994, we identified people who had symptoms for major depression episodes, and we followed them over all available cycles looking for mortality events. So from this survey, we estimated hazard ratio, mortality hazard ratio by depression status. From Canadian Community Health Survey, this is a cross-sectional population survey. We estimated prevalence of depression as well as health-related quality of life for people with and without depression. Our study was limited to adults 20 plus, and we had very good response rates from Canadian Community Health Survey and National Population Health Survey. So mortality for the total Canadian population comes from Canadian Chronic Disease Surveillance System, and Louise gave an overview of the system, so I'm not going to repeat anything that is presented on the slide. So we use data of mortality and population data for 2007-2009 from this system. And we partitioned those rates by depression status using these formulas, and we derived those formulas while working on our Health Adjusted Life Expectancy by Body Mass Index project. And these formulas can be used to estimate mortality rates by disease status, by risk factors, and by social economic status, for example. So how we define depression? Depression was measured in both surveys using a composite international diagnostic interview short form instrument. The CD instrument was developed by World Health Organization and was adopted to use in Canadian survey. So we had a short form of this instrument. It was based on diagnostic criteria from International Classification of Diseases and Diagnostic and Statistical Manual for Mental Disorders. So this instrument produces scores that give predicted probability of depression. So we identified people with depression as those who had a predicted probability of 0.9 and above. And so this identifies them as having experienced a major depression episode during the previous year. So to estimate life expectancy in HAIL, one needs to build life tables. So we use chunk method to build a bridge life table with adoption of HAISH method to gloss the table at the very last open-ended age interval, 85 plus. And to calculate HAIL, we use Sullivan method, where we used Health Utility Index Mark 3 as a measure of health-related quality of life. The Sullivan method is only like one additional step to the chunk method that would allow to partition years lived into years lived in full health and years lived in unhealthy state. So to calculate confidence intervals around our point estimates for life expectancy in HAIL, we built 250,000 life tables by sex. And by doing this, we were able to estimate, to look how life expectancy in HAIL varies depending on the bootstrap sample we use from CCHS and National Population Health Survey. So all data were done using SAS. So we develop a set of SAS macros to do so. And as a measure of health-related quality of life, we use Health Utility Index, which is a multi-attribute health status classification system that defines states according to 8 attributes, such as vision, hearing, speech, ambulation, dexterity, motion, cognition, and pain. So each of these single attributes has 5-6 levels of functioning. And so for each level of function, there is a weight assigned by the expert panel. And the mean HUE was derived using this utility function component. So it goes from the minimum value minus 0.6, which is considered state as worse than death, through 0, which is death, and to the maximum value of 1, which is considered as perfect health. So, and this slide just shows you the decomposition technique, how we looked at the HALE difference and look what is the contribution of this difference, differences in mortality and differences in morbidity between population with and without depression. And before I go to the result, I should mention that it's important to note that estimates presented in this study should be interpreted only at population level, not at individual level. So it's useful for better understanding the population health impact of a condition, but should not be used to predict the future health expectancy of individuals. Sorry. So on this slide, you will see remaining health-adjusted life expectancy for males and females with and without depression. So the top 2 bars are for those with depression, and bottom 2 bars are for those without depression. So the difference in health-adjusted life expectancy between those with and without depression was about 15 years. And we estimated that a majority of those years can be attributed to the differences in quality of life in approximately 12 years for females and 13 years for males. And the remaining years, 3 years and 2 years, are due to increased mortality among women and men with depression. These 2 graphs shows you the life expectancy in HALE by age, males, females, with and without depression. So you can see that health expectancy, all health expectancy lines are lower than the life expectancy, and you can see that it's decreasing with age. This graph shows you the life expectancy for people with and without depression by sex. So the total bars are life expectancy, and the blue part of it is health-adjusted life expectancy. So the red part is the burden of depression or burden of disease. So it's a number of years people live in unhealthy state. And percentage basically defines the proportion of life people live in unhealthy states. If we compare the proportion of life people live in unhealthy states for those with depression and without depression, so we can tell that almost 3 times more years are spent in unhealthy states among those with depression compared to those without the condition. And these 2 graphs shows you the difference in life expectancy in HALE on the number of years spent in unhealthy state and the proportion of life spent in unhealthy state by sex and by the depression status. This is the number of years spent in unhealthy state, and this is the proportion of life spent in unhealthy state. So we can see that it's much higher for those with depression compared to those without depression, and for number of years spent in unhealthy states, it decreases with age, but the proportion of life spent in unhealthy states is increasing with age. And this is just summary table for decomposition of HALE difference in age 20. So it's the beginning of our life table. So as I mentioned previously, the difference inhaler between those with and without depression is about 15 years for both males and females, and majority of those years can be attributed to the difference in morbidity, but some portion of those years also can be attributed to elevated mortality among those with depression. And when we looked at health utility index components and the difference between population with and without depression, we found that three components of that index are mostly responsible for the difference in health-related quality of life. It is emotion, which is not surprisingly when we talk about depression, but also we found that the difference in pain and difference in cognition are different between those with and without depression, and it's also well documented in the literature. So to conclude, we found that population of men and women in Canada who experience depression live a substantially higher proportion of their life in an unhealthy state compared to those without depression. So the health gap in life expectancy between Canadians with and without depression is primarily associated with losses in quality of life. And we found that emotional state, cognition state, and pain are the key attributes associated with losses in quality of life. So we identified some policy implications of our studies. We think the findings of this project validate the very real burden experienced by people living with depression. And it is signaling that this is a legitimate and necessary area of focus for policymakers. So finding of our study can support policy action at all levels of government. So mental illness prevention and mental illness promotion activities can be a policy response to these findings. So the connection between physical and mental health is clear, reinforcing the need to address both components of overall health. And as any other study, our study has its strengths and limitations. Among the strengths that we use the survey data, which is a population-based samples of Canadian household population. And PHS, which is a longitudinal Canadian survey, allowed us to follow a mortality experience of Canadian population with and without with depression for 16 years of follow-up. And among limitations are that we also only considered the first probable episode of depression in NPHS when we estimated mortality hazard ratio using CD short form, and perhaps in future it makes sense to redo the study and to allow the depression status vary over time. So the CCHS was a household survey, and it excludes other populations such as those living in institutions and long-term care facilities. It is known that people in correctional services and long-term health care facilities have increased level of depression, so our findings may not reflect the estimate that is valid for entire Canadian population. And the CD short form also may underrepresent the prevalence of depression in the Canadian population due to the false positive, so it may also affect our estimates. And thank you, and this is the information for the corresponding after. We are going to publish this paper hopefully soon, and if you will have any question, you can send it my way or to the Bernard Choi, who is going to be corresponding after for our paper.
Great. Thank you very much, Lydia. And we're doing very well for time, in fact. We had anticipated having about 20 minutes for questions and discussion, but we have now about just under 35 minutes for questions and discussion. So lots of time, I think. And there's lots of really great questions coming in on the text chat, so keep those coming. We'll try to address as many as we can with the time we have remaining. And we'll start with Natalie. And the question is, I think it's directed to Shaban. And a question, how were the types of self-management surveyed chosen? Use of light therapy, as far as I'm aware, is primarily used for SAD, and isn't generally considered a non-seasonal depression?
Most of the self-management strategies were based on what has been offered in the clinical practice guidelines that are published, as well as in the literature. It's correct. Light therapy is used primarily for SAD. So analysis would have to, that question was only asked of those that self-identified as having had mood and anxiety disorders in general, but we could subtype it out looking at those with SAD only.
Next question from Catherine. Does the CCDSS summarize data regarding residents of Canada also exclude Aboriginal populations? And a similar question that came in from Sarah, does it include the incarcerated populations?
Aboriginal populations are included. All individuals who have the health card basically are included. However, we're not able to, there's no identifier, unfortunately, to be able to identify Aboriginal status within the data. So we're not able to do that analysis, unfortunately, to be able to look specifically at Aboriginal populations. As for the incarcerated populations, any federal data sources are not included. So anybody in a federal institution, we're not able to include them. My understanding would be then that anyone within a provincial institution would be included.
Great. Next question coming in from Shirley. Do you know how much of the youth is represented in autism spectrum disorder? I think this is for Louise.
Autism is actually not an area that we include in our mental illness surveillance. It's another group within our division that's on developmental disorders. So unfortunately, that's not a question I can answer. I'm not sure if they happen to be on the agenda for a future webinar, but it's something that we can put you in touch with the right person if you want to follow up with us directly afterwards.
A question from Judy. I think this is again to you, Louise. Did the CCDSS survey for the use of other treatments such as TCMR, CBT, electronic mood tracking apps, etc.? And the second question, did you look at concurrent disorders with addiction?
Okay, in terms of specific treatment modalities, we're not able to get to that level of information. It's basically whatever's recorded in or submitted in a billing report from the physician's office or hospitalization. So at this point, we can't look at that information. When we have tried to do some work looking at specific procedures for different conditions, we find that there's a lot of variation across the provinces and territories in how they record that information. So it's pretty complex, and we're not there yet. And what was the part two of that question? I'm sorry.
It was, did you look at concurrent disorders with addiction?
We have actually. We did some feasibility work on substance use disorders. However, what we were finding was that the rates were quite a bit lower than we would expect based on survey data. So our sort of recommendation from our working group at this point was that we can continue to collect that information and monitor, but at this point it's seeming like individuals with substance use disorders are not being captured within the healthcare system. So that's another one of our limitations in not being able to capture some of those community health services. So that's a gap that we are looking at ways to fill. So stay tuned.
Great. Next question from Richard. Do you think increased use of services by women indicates a higher prevalence of illness or an increased likelihood of seeking and receiving services?
That's the $100 question. It's probably a bit of both. There is, we talk about that a bit in the report in terms of there are differences in the way that, in the rates at which women versus men seek health care. So I don't recall from the survey data, I guess it's still higher in women than men in the self-reported data in the survey.
Correct.
But then there's still the question of maybe women are more likely to report. So it's really hard to flush that out. But
another question from Daljit. Will future reports be able to identify mental health and mental illnesses by ethnicity?
it depends on the data source that we're using. CCDSS, no, at this point, unless we're able to link to another data source that can provide that information. Currently, it's not included in the administrative data, so we're not able to within CCDSS.
Within the survey of living with chronic conditions that we presented, we did look at ethnicity. However, due to sample size restrictions, as I mentioned, we weren't able to disaggregate in any really meaningful way because the majority of people were Caucasian, and the other subtypes of ethnic types were just, the numbers were too thin. So we were limited in our analyses that I had mentioned. We were doing a suite of papers, and we were limited in not being able to report on ethnic differences, unfortunately. But that's not to say that survey data doesn't permit or support that analysis in our regular Canadian Community Health Survey, where the numbers are much more substantial. This was a follow-up survey, so it was only representing a very small proportion of the overall source survey. So certainly we could, look at ethnicity using the CCHS.
And I think we plan the feasibility study to link CCHS data with CCDSS data, so perhaps in future we can also use CCDSS data and disaggregate it, at least portion of it by ethnicity.
Sure.
Thanks. And next question from Melissa. Are you able to assess risk or preventive factors associated with the development of mental illness and mood anxiety disorders?
Is that pertaining to the SLCDC data source, you mean? Was that question in relation to, because I can answer from that perspective. It's a cross-sectional survey, so we can only look at associations with regards to mental illness outcomes. This was not designed for that purpose, though. The SLCDC was truly just profiling the experiences of Canadians, and we can look at risk factors that are associated with it, but certainly because it's cross-sectional, there's no causation that can be inferred at all, but we can say that, describe the risk profile and say whether there are certain associations, yes, but among those with mood and anxiety disorders. But because it's only those with mood and anxiety disorders, we don't have a referent group.
Next question from Michael, and it's to Lydia, I believe. Does the HALE estimates take into account that individuals with depression may experience a remission?
No, we actually didn't look when we estimated our mortality hazard ratio. We only look at the depression status at the baseline, and we didn't follow and we didn't look how the status changed over time. So our population with depression basically consists from people who has both chronic and episodic cases of depression. And for that reason, we cannot basically apply our estimates to any individuals with depression. It's only a measure for the population in a given time.
Thanks, Lydia. Another question around HALE. How can HALE be used for the evaluation of programs and policies?
When I show you the survival curve and then blue area, which is a number of years spent in poor health. So ideally, over time, when we produce our policy and programs, that aim to reduce health of Canadians. If this gap decreasing over time, and we will do it again, say this study again in the 5 years, let's say, and we again evaluate the health gap, so it would mean that our program and policies related to the reducing this gap works well. If not, so we'll probably have to adjust our policy and program. So it can be used as a measure for evaluation purposes.
Thanks, Lydia. Next question for, I believe this is for Louise on the CCDSS. What are the future plans for the CCDSS in terms of national surveillance of mental illness?
Well, we will continue to conduct our surveillance of mental illness overall, as well as the mood and anxiety case definition as well. We are also in the process of doing a national pilot with schizophrenia and delusional disorders. And we are continuing to explore indicators of chronicity, so in terms of recurring episodes in episodic mental illness, and indicators of mortality. And as other conditions are added into CCDSS, we will also explore the comorbidities, additional comorbidities. So lots of work to do.
Certainly. And next question, what efforts has the agency made to use electronic medical records for the surveillance of mental illness?
We have, well, for example, we currently have projects underway where we are linking Ontario and Manitoba, doing sort of a triangulation of the 3 data sources of the CCDSS, and the electronic medical record systems and survey data. So this will, it's linking all 3 of these together and looking at the pairings of the data as the data sources as well. So looking at where the overlap is and what's missing by looking at only one of the 3 data sources. So it should be a wealth of information, and so we'll be getting the results of that project within the next few months, and looking at the implications of it going forward.
And next question for Shaban, what other conditions have been covered by the SLCDC?
In 2009, we conducted a survey on arthritis as well as hypertension. Following that, there was a survey focused on diabetes and chronic respiratory conditions. Followed by, there was a survey that was also done on looking at neurological conditions. And finally, the mood and anxiety disorders, which was done in 2014. The plan is to take sort of a respite for the SLCDC at this point in time, because the center is focusing their attentions and resources and energies towards upstream. So so we're looking at supporting more the children's survey seems to be more of a focus at this point in time, but so we don't have any future cycles planned, but it always can be resurrected should there become an information gap or a knowledge gap that needs to be addressed in the area of looking at experiences with regards to impacts and management in another chronic condition.
Great. A question coming in from Judy, and she asks, any data prevalence of mental illness in the justice system? And I think there was, it was the same question. So that's any data on prevalence of mental illness in justice system?
Correctional services, I believe they do report on mental illness within their populations. I actually don't have that information at my fingertips, but maybe I can provide a link of some description after the webinar.
And question, why were psychological services not included in the CCDSS?
This was, unfortunately, we're only able to include those who are captured under provincial and territorial healthcare services such as physician billing and hospitalization services. So at this point in time, there's no standardized data collection of psychological and community mental health services outside of the healthcare system. So it is a gap in the CCDSS. We are exploring ways that we might be able to at least identify the size of this gap, if not fill it at some point further down the road.
And next question from Daniel. You mentioned that the survey you talked about in regards to mood and anxiety disorders, that the lack of exercise and non-pharmacological methods of managing these disorders was evident in the statistics. Do you have any idea of this being a result of overprescribing anti-anxiety medications and psychiatric medications in treating these disorders?
Unfortunately, that question can't necessarily be answered from the survey data. So maybe actually, could you repeat the question? Because I think I missed the latter part.
Yeah. It's in regards to the survey and mood and anxiety disorders. And you mentioned that the lack of exercise and non-pharmacological methods of managing these disorders was evident in the statistics. And so Daniel's wondering if could be a result of overprescribing anti-anxiety medications and psychiatric medications.
Oh, sorry. Okay, I understand a bit better now. Well, certainly, as you can tell from the numbers, that the majority have either are currently or have ever taken prescription medications. So it would appear from the survey data that it seems to be the first line of treatment, with self-management, engaging actively in self-management strategies kind of lingering behind. So it definitely tells that story. We are looking and exploring these topics in more depth in the papers, specifically looking at, those that are taking medications and we do cross-tab that with if they're doing other things, if they're not taking medications. So it's interesting to see that maybe they're self-managing, that small subset are managing through other means other than medications. But I would agree that the majority, 93%, have said they are currently or have ever taken meds, and it is the predominant method of managing these conditions in this particular population in the survey, according to the survey respondents.
Great. Hopefully that helps Daniel. Another question around HALE. What other measures of HRQL can be used in health expectancy calculations?
Yeah, in our study, we used the Canadian Measure Health Utility Index, which is not available in other countries, but in other countries, researchers estimate health expectancy, not necessarily health adjusted life expectancy. They estimate different type of health expectancy, and they usually use the measures available in their respective surveys. Usually prevalence of good and excellent general health. So you can use the prevalence to partition the years lived, total years lived, into two components: years lived in good and excellent health, and not that health, the other complement population.
Thanks, Lydia. Next question for Shaban. What are the strengths and limitations of SLCDC?
Well, in terms of strengths, it is a national population-based sample of mood and anxiety disorders under study, so it does provide that perspective, of course, across all Canadian regions. Another strength is that it's a fairly innovative survey design. The responses can be linked back to the CCHS, which really maximizes and comprises a rich data set because you don't have to ask all the questions over again. So you do have all that demographic information and other information from the CCHS that can be linked back. The quality of the way that the surveys, the respondents are sampled and the way that the questions are administered, they're highly trained personnel, and it's carried out in a very standardized manner. In terms of limitations, as I touched on before, it is a cross-sectional survey design. So there's no causation. We are literally just describing the experiences. We can look at some associations, but we can't really suggest there's any causation here. The sample size did limit our ability. As I've mentioned, we couldn't provide provincial estimates, only regional. Some indicators were limited in terms of our ability to break it down by age and sex, especially among males, and also our inability to explore issues in vulnerable populations and at-risk groups, like as I mentioned, in terms of certain ethnic groups. And that's probably the primarily sums it up. But it does, and it has been very helpful to us, though, in terms of being able to address a knowledge gap in a fairly cost-effective way. It is a one-time survey, but we could always repeat it if there needed to be and a reevaluation of how perhaps Canadians are experiencing and interacting with the healthcare system and how they're managing. But it's a good snapshot, provides a good snapshot of the experiences of Canadians with these disorders.
Great, thanks. So I think we've made it through all of our questions. I don't see any more coming in at this point. And so we've still got a few minutes left, but in the last few minutes that we've got remaining, I wonder if our presenters would want to leave us with some final thoughts in terms of, so what does this mean, what's next, what are the implications for different folks from policy, practice, research, and then also maybe just you want to maybe perhaps mention a little bit about those key resources that we've got listed on the slide.
Thanks, Bill. So going forward, I think we've mentioned some of the things that we'll be continuing to work on in terms of the expansion of the CCDSS, and we'll be continuing to report on the survey data as well. I think that the products that we listed on the slide included the CCDSS Mental Illness in Canada report, the fact sheet from the Survey on Living with Chronic Disease in Canada, and a link to the InfoBase. I believe the link for the InfoBase, if you explore the InfoBase area, within one of the menus there is a data visualization area, which is where the data blog lives. So from there you'll be able to see the mental illness data blog as well as other chronic disease blogs.
I think that there's just a few thoughts as there's been a lot of activity in this area in the last year. Some really excellent information has come out. We're looking forward to releasing the upcoming report on mood and anxiety, and that's going to be generating further work. So I would just encourage you, if you have any work that you think that we should be aware of, or if there's linkages that you think that would be beneficial to moving the work forward, is to contact. I think the contacts for both Lydia, Siobhan, and Louise are posted, and we'd really like to hear from you.
Oh, I just see one more question coming in from Daniel. What were your biggest findings in the geriatric population?
Well, I think from the CCDSS, we were observing higher rates of health service use among the senior population, and as part of that is likely due to the inclusion of codes related to dementia that fall within the mental illness chapter.
Any final thoughts from Louise, Siobhan, or Lydia, or Jeanette before we sign off?
Well, I wanted to thank everyone for attending and sticking through with us, and echo Jeanette's invitation to reach out to us and communicate with us in terms of ideas or questions. We're willing to hear.
Yeah, and it's Jeanette. I just to say thank you again, to repeat what Louise is saying, but I understand that the interest in this particular webinar has been extremely high, so I think that shows the level of engagement on a variety of different fronts in this particular area. So, once again, please let us know if you feel there's linkages that can be made, and if you have any further questions on our work, we'd really be happy to hear from you.
Great. So thank you very much, Louise McCrae, Siobhan O'Donnell, and Lydia Lukin. and Jeanette as well, our guest. Really appreciate you presenting on the webinar and sharing this information with us. I wanted to echo our presenters as thanks to all of you participants for joining in and taking time out of your days to share and discuss and learn with us. And thanks as well to all of the larger planning group behind the webinar at the Public Health Agency of Canada. It's really been a pleasure working with you to plan and host this webinar, and we're looking forward to our upcoming webinars through the rest of this year and next. So with that said, I just want to thank everyone and hope everyone has a great rest of the day and have a great afternoon.